either supplementing their income by working in this role or like doing it primarily, perhaps, because they don't like doing clinician. I mean, I think they're always private practice. But like, I don't know what their incentive structure is, because I'm sure they're incentivized to reject claims reasonably and
to the Lung Cancer Living Room, coming to you live from Colorado. We're really happy to be out here in Cherry Creek tonight. Thank you for having us. Welcome to everyone signing in online. My deepest apologies for the delay. We were having some technical difficulties from this beautiful room that they have set up for us. For those of you who don't know me, my name is Danielle Hicks, and I'm from the Bonnie J. Dario Lung Cancer Foundation. My role at the foundation is overseeing all of the patient programs and services, education that we provide. Of course, I don't do that by myself. I have an amazing group of people working with me, 2 of whom are with me today. And as we go around the room and do introductions, I will have them introduce themselves. For those of you who have watched in the past, you know how this works. For those of you who have not, we really want it to be interactive. The reason we put this together is for you. So you can have an opportunity to ask questions of our expert panel that you otherwise wouldn't have an opportunity to do. We have 2 hours of their time, so let's make it work in a way that you want to make it work. So I really encourage Q&A throughout. If you just raise your hand, because we have one handheld mic, I will run around the room. At some point I might have to take off my shoes, but I will run around the room and make sure that we get to your questions. So please, please, please don't forget that. I think I already asked everybody to check their cell phones. That would be great. Well, I'm going to start with the around the room, and I'm actually going to start on the left. And I'm going to ask you guys just to pass the mic. You do not have to introduce yourself and say who you are. I'd like you to make it quick, who you are, why you're here, if you're a patient, when were you diagnosed, anything quick you want to share about that, anything of special concern to you that you want our panelists to be aware of so that they can address it during the conversation. And if you're not a patient, why lung cancer matters to you, why are you here? So with that, I'm going to pass the mic over this way.
Hi, I'm John Skater with the International Association for the Study of Lung Cancer, so that's why we're very interested in lung cancer.
My name is Peggy Dennis. I was diagnosed in July of 2016, so I just hit just over 2 years. I'm glad to be here.
My name is Collin Barton. I was diagnosed with ALK-positive lung cancer around about May 2016. And we have a online support group called ALK-positive, and I've had quite a few conversations with Dr. Camage, and I'm here at the invite of Dr. Camage.
Hi everyone, my name is Deb Vogel. I work for the Cancer Centers of Colorado at St. Joseph Hospital, so I'm very interested in being here. Thank you.
Is the mic working?
Oh, this is what I also should tell people. So the mic doesn't actually work in the room, so talk as loud as you can. It's for the people online so they can hear you. If we had this mic working in this small room, we would all probably need earplugs. So just talk as loud as you can. Thanks.
Hello everyone, I'm Kim Parham and I'm with the Dario Foundation and I do patient navigation and clinical program development. Thank you for coming.
Hi, I'm Joy Brewster. I was my dad's caregiver. I work for Survive It, and I'm supporting my fiance, Chad.
Hello, my name is Carsten Schnadwinkel. I'm primarily here to listen and hopefully provide better health care to those patients that need better health care in general.
My name is Kristen Rickheimer. I'm with the International Association for the Study of Lung Cancer, and I work with our members and also patient advocates. So we're just really interested in the exchange between physicians, patients, researchers, and learning more and about what ISLC can do.
I'm Steve Barnard, and I'm here supporting my wife, who's a patient.
I'm Chris Barnard. I was diagnosed in January 2017, ALK positive.
Sharon Lundy, I'm with Colorado Cancer Centers, and I'm a lung navigator, so all things lung matter to me.
Hi, I'm Ann Phillips, and I was diagnosed in May of 2015, and I'm a patient of Dr. Camage's.
I'm Lisa Moran. I was diagnosed in August of 2015, and I am an EGFR resistor.
Hi, my name is Allie Coffey. I am a patient of Dr. Camage's, diagnosed in February of 2016, EGFR positive, also T790M mutation, and now have advancement with sort of leptomeningeal disease, which is freaking me out, but I'm here. And I'm glad to participate and see what new information I can glean tonight.
Hi, my name is Aida, and I'm going through this with my wife, Ali.
Hello, my name is Kristen Schultz, and I am also with the International Association for the Study of Lung Cancer, and I'm a patient advocacy specialist, and I'm here to learn more on how to be a better advocate.
Hi, I'm Becky Bunn, also with the International Association for the Study of Lung Cancer, here to help amplify the message and to help raise awareness.
Hello, my name is Tanner Balch. I am here with Biopsy. I'm a patient advocacy specialist. Biopsy does genomic and proteomic testing for non-small cell lung cancer patients.
Hi guys, Jamie Ikeda, also with Biopsy. I'm on the marketing team.
Devin Forster here with Biopsy as well. We're here just to try to improve patient outcomes, and really happy to be here.
Kayla Hopper with Biopsy as well. I'm actually part of the patient advocacy department with Tanner, and we're just here to try and learn as much as we can about how we can help people moving forward.
My name is John Lumpkin. I'm with AstraZeneca, but also have two close friends that are currently battling lung cancer. So.
And Wendy Shaver with AstraZeneca, and I do patient education throughout the state of Colorado.
Hi, I'm Michelle Zay. I work for the Adaria Lung Cancer Foundation with patient services and programs. Thanks for coming.
So I will say that Michelle and I were in, and Kim were, and one of our other colleagues were in Florida last week doing our living room out of there from Hollywood, Florida. And I shared with Janet tonight, who you guys will meet in a minute, if you haven't already met her, that Florida was our sort of, kickoff to not only live streaming this via our YouTube channel, but also doing it live on Facebook. And through our Facebook, I don't have the stats from YouTube yet, but from Facebook, it's already reached like almost 4,000 people and been viewed almost 2,000 times. So since Thursday, which is actually a really, really huge thing. So Facebook is proving to be a really good way for us to kind of transmit this program out to the world. Dr. Camage has come out to California and participated and spoken at our living room in the past. We do this monthly, the third Tuesday of every month, 5:30 PST, and we do 6 on the road. So there's 18 of these opportunities for all of you to interact. So thank all of you for being in the room tonight. And with that, I'm going to turn it over to our panel, and because they can always do a way better job than I can of reading from a piece of paper who they are and why they're interested in lung cancer. What I've started doing over the last several months is asking them to introduce themselves, talk a little bit about what they do and why they chose lung cancer. With the exception of Janet, she's going to tell you why lung cancer is important to her, but why these three to your right chose lung cancer as an area of specialty. So, Derek, can we start with you? You don't need a mic, you're mic'd.
Right, I'm mic'd. I'm mic'd, but you might have some trouble hearing me. I'm
suffering from a little bit of hoarseness, so pardon me. And I might need to get somebody to restate what I say if my voice goes out completely. So my name is Dara. I'm a pathologist and molecular pathologist. I primarily work with lung cancer from a diagnostic pathology perspective, but I'm also the director of a molecular pathology lab where we do the personalized medicine testing across a spectrum of many tumor types, of which lung cancer is one. Although I run a laboratory that tests many types of cancer, including colon cancer, melanoma, brain tumors, my personal and research interests really focus on lung cancer for a number of reasons. One of which is just serendipity, that when I started in my position at the University of Colorado, I went to them and I said, well, I'm absolutely dedicated to doing molecular pathology. That's the thing I want to do. What other thing would you like me to do? And they said, well, we could use somebody else in lung. And that's how it is that I've come to work with this incredible group of people at the University of Colorado, a central real powerhouse in lung cancer research and treatment. It's been my privilege to work with this group and get to know so many of our patients. So that's me.
And I'm Chad Rusthoven. I'm a radiation oncologist at the University of Colorado, and I work with Dr. Camage and Dr. Eisner. And I became interested in lung cancer for a number of reasons. I actually did my training at the University of Colorado, and so I was friendly with Dr. Camage and some other people in our department during that time, and I was very impressed with what was going on in our program, but also with lung cancer in general. I feel like it's probably one of the fastest moving areas of cancer research. Notably in systemic therapy, there's always new therapies that are coming out that are very effective, that are improving outcomes, but also from the radiation oncology side, it's an area where we're really able to utilize higher levels of technology to deliver more focused treatment that's more convenient for patients and more effective in treating tumors. And there's, as new therapies are coming out from the systemic side, we're always trying to figure out how to best integrate the role of local therapies like radiation and surgery with those treatments to both improve patients' oncologic outcomes as well as their quality of life and their experience. And so it's always moving. And also, you know, I was offered a job to stay on here, and it was just a very obvious choice for me that I wanted to be a part of this program.
I'm Ross Camage. I'm the director of the Thoracic Oncology program in Colorado, and I'm going to toot their horns because they've been very modest. So Dara's like the world's most amazing molecular pathologist. And Chad, we have an amazing program for training radiation oncologists, and Chad is the only one for years that they actually offered a job to. And even though they're that good, he was the best of the best. And also he can actually speak English and explain what radiation oncology is, which was kind of neat too. So why lung cancer? I really like the people. I don't know why nice people should get lung cancer, which I think is a terrible thing. But if I have to interact with people, it's nice that they're nice. And I feel that the field is changing so rapidly that we as a team can actually not just contribute sort of day-to-day care, but advance the field, which we have done multiple times, and I hope we continue to do so. But I'm delighted to be here tonight.
I'm Janet Freeman Daly. I didn't choose lung cancer, it chose me for some reason. I have ROS1 positive cancer and have been on a clinical trial at the University of Colorado for 5.5 years, and also work with them as one of their research patient advocates, and I'm one of the co-leaders for the ROS Wonders, an advocacy group for patients who have ROS1 positive cancer.
Thanks, everybody. So with that, Michelle, is there anybody online who wants to say hello or introduce themselves? Everybody's just listening. Okay. Make sure they know. Make sure you guys know whichever camera I'm supposed to look at. Please ask your questions because Michelle will ask them on your behalf. And then with that, I'm going to turn it over to the team. And I'm going to start with Dr. Camage, but then I'm going to ask everybody to kind of talk a little bit about the very first question. and we don't have to stay on script at all. So if you guys, if something
We're
pops,
not going to. Don't worry
I
about it.
totally know we're not going to. Trust me. I know that's what's going to happen. But because the topic tonight is the importance of a multidisciplinary team, I think it's important for those who may not know, those who are in the room, online, or who will come back and watch later, what is a multidisciplinary team and why is it important? Who are the players? What do they do? And why is it important that every patient have one?
So it's a bit of a buzz phrase, and you hear people talk about multidisciplinary team, but it is what it says. It's one individual can't know everything, and we all have our biases and our prejudices, and so by getting together people who have different views on the same problem, you can help each other out, and so the team. It's very large, and sometimes there's the patient-facing side, which people might experience. So that's the treating aspect, which will be surgical oncology and radiation oncology and medical oncology, and to some extent pulmonology. But then behind the scenes, we have people like Dara, who are pathologists. We have radiologists who look at the scans, and then we have all those other supportive services like social workers and dietitians and pharmacists. And what you don't see, your ears if you're a patient, your ears should be burning all the time, because we do talk about you behind your back. And it's not just, wasn't so-and-so terrible today, but it's more kind of like, well, what do you think about this? And what's the latest breakthrough in this? And what's the best way to work together? So that's what a multidisciplinary team is. One thing it's not, and I was chatting to Collin about this, it's not a corporation. It's not a way of removing responsibility. You still have a doctor, and your primary doctor is the one responsible for you, but it's about putting people's heads together to get the best for one person who that doctor is responsible for.
How does a patient know whether or not they have a multidisciplinary team? Do they?
Well, if they have to ask, they may not have a multidisciplinary team. So again, it kind of depends on the vagaries of infrastructure. So in big programs, everyone's working in the same center and is in the same physical space, and so you can have this interaction all the time. Sometimes you can jerry-rig that. If you happen to be a standalone oncologist, you may still have a great relationship with a surgeon and a radiation oncologist, but they may be in separate practices, and so physically you're sending people around. You can email and you can phone, but a true multidisciplinary team is often where literally you can all be in the same room at the same time, sometimes even with the patient, so you can, throw things around.
So this is where I'm gonna start to take it off script for just a second. So I'm Janet.
Hello, Janet.
And you're my treating physician.
Okay.
This is where this whole the idea of shared decision making and what that conversation, what does good look like, that conversation between physician and patient, right? How do I know that you and Dr. Rusthoven have had a conversation about my case? Are you telling me? Does that always happen? Why is it important that it does happen?
Well, Chad could talk about this, but I have a clinic on a Tuesday and a Wednesday, and pretty much I phone Chad pretty much every week. You're probably expecting the phone call, and more often than not, he will see that patient same day. It's not unusual for him to literally come up the stairs, and he's physically there in the room with me. And there's no substitute for that. We're discussing things in front of the patient, and the patient is part of that dialogue.
So go ahead, Janet. Yeah.
So, and it's different in different institutions. So I was treated originally in Seattle, and the multidisciplinary team there was trying to evaluate whether or not a particular nodule was something that they needed to do something about or not. And my pulmonologist walked in the room and said, I talked to the tumor board last night, and told me everything that they'd discussed. So
and at that point, from a patient perspective, did you know what a tumor board was?
Well, by that point I did. The first time you did what? So, but by the way, you mentioned, how would I know if my treating physician does? He knows I'm going to ask him at this point.
Yeah, and so the longer I think patients are in sort of the post-diagnosis, the more likely they are, in some cases, to ask these sorts of questions. But I think this is where meetings like this are so important, so that patients who don't know to ask these questions hopefully will see this and know that it's an important part of the, yes, I'm coming. It's an important part of the process. I'm going to duck.
So I was wondering, if my my case was presented to the tumor board, is the tumor board part of my multidisciplinary?
Well, it is and it isn't. So it's not every decision has to be run through a committee. You know, you and I can talk about things and make a decision between ourselves. I don't have to sort of externalize that decision making. But I think for a difficult thing where I want to get different opinions, I can do that. Sometimes that's going on behind the scenes and you don't see that. I mean, you don't have, so the funny thing with tumor board is in their worst example, they're a way of people kind of obviating responsibility for what they're doing. And I don't like that. I think what, in their best cases, they're a group of smart people you can bounce ideas off, but still the person who brings that case, it's their job to synthesize all of that, and then they still have to make the decision in collaboration with the patient. If the team says, you know, we should go left, and the physician and the patient says we should go right, you can still go right.
So, yeah, I think that.
I did.
Oh, Derek, who was talking? Sorry,
go ahead. So can I presume that if the facility I'm going to is a comprehensive cancer center, that they have multidisciplinary teams?
Yes, I think so. I mean, Chan, do you want to? I mean, radiation oncologists, I think, did you always in a multidisciplinary team?
Well, yeah, we're kind of a consultant's consultant. We're downstream typically of the medical oncologists, which are already a specialist. So by the time that, in most cases, that a patient gets to us, they've already been thought about by several people who have expertise in cancer. So in some ways, that's probably true, though I think that you know, at a university, there's a lot more emphasis on kind of getting together face to face and having things like tumor board and having offices close by where we're actually all under the same roof. That's not to say you couldn't have that in other places, and there are other examples where that can be the case, but I think that's one thing that you will often get at a university.
So
what I was going to say about, what I was going to say about this is that for a lot of the components of multidisciplinary care, they happen one way or the other, right? If you get a biopsy, a pathologist is going to look at it. If you get a CT scan, a radiologist is going to read it. If you get a pulmonary function test, it's going to be evaluated by a pulmonologist. The major distinction is that at some point in time, we all come together and we can not just bounce ideas off of each other, but we can take into account a whole picture that's otherwise very hard to take into account if you're just looking at your one little slice of it, right? So, for example, in tumor board, we might have a case that just seems, oh, this is so obvious what should happen, and the social worker will pipe up and say, well, but this patient lives 6 hours away and doesn't have great transportation. Aha, that changes things, right? So what do we do with that new piece of information? And I think a lot of multidisciplinary care is taking all of these fragmented pieces of information and having people just focus on all of it come together, even if it's only for a couple of minutes, right? Just bring all of it together to look at it at one place, one time, and get everybody's eyes at the same time looking at it. And it makes a really big difference. There are a lot of aha moments.
I agree. I think there's basically what you're saying is it's sort of de-siloing, right? Asking everybody to come out from the amount of information they've received. The radiologist, looks at the scans and that's what they have. But until the conversation happens, right, with how are we going to, biopsy this and what does that look like and molecular testing, so on and so forth. So I want to step back for a second before we talk about some of the challenges and where not you may be receiving multidisciplinary care, and talk a little bit about each of those team members and what they do. So Dr. Kamich can speak, obviously, to medical oncology. Dr. Rusthoven can speak to radiation oncology, and Dr. Eisner can speak to pathology, and then I'll ask a combination of you to talk about some of the other players. So whoever wants to start.
So for radiation oncology, when we think about what types of oncologists there are, overall, you can break up oncologists into generally into three types. So there's medical oncologists, like Dr. Kamich, who deliver medical therapy, so medications that can be delivered either via IV or orally. And so that's one type of oncologist. And then there's oncologic surgeons who actually do the cancer surgeries and remove cancer. And then there's a third type of oncologist called a radiation oncologist, and that's what I do. And so that's a specialist who actually uses radiation to treat cancers for various reasons. And we all kind of work together. And so depending on what type of cancer you have and what stage of cancer that is, and what we think the best treatment for you is, you may be seeing one or two or sometimes even all three of us at different times, and we all kind of work together as a team. And so from the like day-to-day of what a radiation oncologist does, in some ways it's similar to what medical oncologists do. We see new patients and we talk to them about whether we think that radiation could potentially be helpful in their case, and we make a recommendation about whether radiation is indicated, and then talk to them about what that would look like. So would that be one treatment? Would it be several weeks of treatment? What side effects to anticipate? What are our goals with the therapy? Are we trying to get rid of the cancer forever? Are we trying to improve pain or some other symptom? And so kind of defining those things and really spending a lot of time face-to-face with people to answer their questions and make them feel comfortable about the idea of radiation, which is a pretty scary word. People bring a lot of ideas about what that might be, or fears to the table, depending on what experiences they've had with family members and friends. So we try to spend a lot of time with people up front to help them understand why we think that this might be a useful therapy in their situation. And then the radiation oncologist, in cases where we do offer radiation, there's a lot of technical aspects of my job. So patients will usually have a planning scan, and then we will work behind the scenes to look at their imaging and define the area that needs to be treated, and then any relevant normal tissues and organs that might be around there that we need to protect. And so that can vary from something that can be done relatively quickly in simple situations to something that may take several days and may take a number of visits between us and going down and actually sitting down with the radiologist and going through the scans with someone who formally reads those, or in some cases with lung cancer it may involve me bringing the surgeon down who actually did the surgery for a patient and having them point out specifically the areas that they're worried about that they saw in the operating room. And then once we've defined those things, we work with our physics staff. So there's a whole, for all the radiation oncologists we have in our department, we have about the same number of PhD physicists who actually help us design the radiation plans. So there's a lot of behind the scenes work that goes into designing something that we think is safe and effective, and so that's kind of the technical side. And then once everyone agrees that we're happy with the plan, then we call patients and we get them scheduled for their treatments. And that can really vary quite a bit from classically the conventional way of doing radiation is a daily treatment, Monday through Friday, for 2, 4, 6 weeks, depending on what's going on. And then with some of the technology we have today, some of our treatments are much quicker than that, and can be delivered in one treatment or 3 to 5 treatments. So there's quite a variety of what patients actually experience with their treatments. And then our job is, while patients are going through treatment, once we've done all this technical work, then really my job is just to support people and help them get through the treatment that we've prescribed, and to respond to new symptoms or to new questions, to really try to help them get through their course of therapy that we think could be helpful in their case. And
so you're seeing the patient during the radiation therapy?
Yeah, so we see patients, a standard, so if a patient's getting 6 weeks of radiation, even if they have no symptoms, we'll see them once a week. But it's our job to respond, on any given day if they're having a new symptom, to make time to talk to them about it and think it through. And then after patients are done, then oftentimes we're part of the follow-up team that may see patients for their scans, at 3 or 6 month intervals after, to make sure that our treatment's been effective.
And then, can I? No, I can't. Go on. Just because you got the microphone. Come on, I want to ask a question. Okay. So, Are radiation oncologists generalists, or are they tumor type focused?
So that
I know the answers to these questions, I'd like to point out.
I feel better, thank you.
So that can vary quite a bit. So for an oncologist practicing in the community, and particularly rural communities that might only really need one radiation oncologist for their entire town, that radiation oncologist really does have to treat anything that walks through the door that has a reason. Any patient that has a need for radiation, they have to be competent and comfortable treating those things. And then as you get into bigger urban areas and big cities like Denver, there's a lot more radiation oncologists, and people start to become a little bit more specialized. And then particularly at universities like ours, there's a lot of emphasis on specialization. So there's myself and Brian Kavanaugh are two lung cancer doctors.
Not Brian Kavanaugh, the Supreme Court candidate, to be clear.
Yes, a different Brian Kavanaugh.
Yeah.
We both treat lung cancer primarily, so we spend a lot of time thinking about lung cancer, and that can vary from very common cases to knowing when things are a little bit abnormal and you have to think outside the box. And then the other nice thing about that is that we have very close relationships with medical oncologists like Dr. Kamich, who specialize primarily in lung cancer, as well as thoracic surgeons and lung pathologists and lung radiologists. And so there becomes kind of this community of specialists who are become very comfortable in communicating with each other, and are very comfortable clarifying things when things are uncertain.
So I'm going to bounce a little bit, at least while these three physicians are introducing their role in the multidisciplinary team, and ask a few questions of Dr. Rusthoven while we're talking about radiation oncology. So it was that question you and I were talking about earlier, one of them. Another one was with Dr. Eisner, but this one is around proton therapy. Number one, what's all the fuss about it? And then number two, you touched on it a moment ago, patients and their fear of radiation therapy and what that looks like. How often can somebody be radiated? How many times? What sort of impact does that have on their quality of life? So 2 questions there.
Sure. So proton therapy. So one thing that can be a little bit confusing is that most radiation oncology departments treat cancer with X-rays, but the actual technical term for that is photons, spelled P-H-O-T-O-N-S, which sounds a lot like protons, and so P-R-O-T-O-N-S. So there can be just some confusion in the nomenclature
there aren't proton torpedoes in Star Trek, just to be clear.
Right, yeah, so that's very important to keep in mind, of course. So most of the radiation that's done in the United States and in the world is photons, which are synonymous with X-rays. And then there's a couple of centers, a handful of centers around the country and around the world that have a special type of radiation called protons. There's actually no proton center in Colorado. The closest ones are in Oklahoma and down in Texas. And so those things exist. And then the reason is, well, why would you travel or think about getting something like that? It comes with a little bit higher price tag usually, and they may not be close to you. So protons, from a purely physics standpoint, basically they have some physical properties that make them attractive, that may give them a theoretical advantage in terms of reducing the dose of radiation that goes to normal tissues. So there's no real difference between X-rays and protons in terms of typically the doses of radiation that we are treating the tumor itself with. So our expectation is usually the same cure rates or the same tumor control rates with either of these things. The difference, the potential difference, is actually about side effects for the patient. And I'm not a proton expert. We don't have protons at our center, but I can tell you in kind of broad strokes that basically there's a physical property about protons that they tend to have a very similar dose on their way in through matter, but then they deposit their dose a little bit more precisely at their endpoint, and then have a lower exit dose. So you can imagine X-rays passing through someone when you do a chest X-ray or something, and you can kind of easily pictured that they have to go all the way through somebody so that you get this image of what the chest looks like. Protons are a little bit better about stopping in a certain place, so they have less exit dose. And so you can imagine that that's kind of exciting from a physics standpoint, because, well, what if we can use this type of energy to deposit a higher concentration of dose in the tumor and less kind of incidental dose in the patient? And so that's an attractive concept, and theoretically it could have applications. There are a couple of places where protons, a couple of disease sites where we think about protons. One is that they have strong indications in the treatment of certain pediatric tumors. And the reason for that is that kids, if you treat a child with cancer, they have, 80, 90 years sometimes to develop secondary side effects. And so we're just very, very interested in trying to lower the integral dose that goes into that child's body, because they have a longer amount of time to develop a side effect from that treatment. And so there's a lot of interest in that. And then the other area where they have some strong indications is in tumors that are in the brain and that are around really sensitive structures inside the skull, like the nerves that are in charge of vision, the optic nerves, and some of those structures, where if you have a tumor that's right next to those things, and you have to be very, very careful because you don't want to hurt someone's vision, for example, you might reach for proton therapy to give you that slight advantage. When it comes to lung cancer and many other cancers, there haven't been, there's not high-level evidence to suggest that protons are actually giving us an advantage over X-rays. And some studies have been done. Dr. Camage and I were talking today about a kind of a high-profile study that was published in the Journal of Clinical Oncology that looked at the treatment of locally advanced stage 3 lung cancers with protons versus X-rays. And actually, there was no difference.
No difference in terms of safety or effectiveness?
There was no difference in either endpoint. So the survival outcomes and the tumor control outcomes were identical statistically, as well as the toxicity outcomes were the same. So the side effects that patients got. And so that's an example which happens in medicine, where you have a hypothesis that something that looks attractive on paper might not always translate into a benefit for the patient when they're actually treated in the clinic. And so the role of protons, specifically in lung cancer, is still unclear and needs to be studied more.
Okay.
So, sorry, I just have a question. Do you have a question?
I was going to, but I know you've got the microphone. But so Janet, you had some radiotherapy a million years ago, right? And you have some scar tissue in your lungs. So would Janet have less scar tissue if she'd been treated with protons? This is the drive-by consult, given that you know absolutely no facts about the case whatsoever.
So that's difficult to say, but based on some of that data that I was referencing, if there are any differences, they'd probably be very minor and might not be meaningful from a side effect standpoint.
Okay. So when you talked, and you may have said this while I was reading, and I'm a terrible multitasker, so I tuned out for a second. But when you spoke about the proton therapy potentially being more effective in the brain when you're dealing with some sensitive areas, optic nerve, blah blah blah, would that be the same when you're talking about the center of the chest, like close to the heart? Would it be the same sort of idea there?
Yeah, it would be. I mean, so the concept is always about when people are trying to investigate protons, it's the theoretical advantage is lowering the dose to the normal structures. So if you're in the brain, you're thinking about things that are involved in vision or other important brain functions. If you're in the chest, you're thinking about the heart or the normal lung that's not involved with tumor.
Or the esophagus.
The esophagus, and so those are things that you always think about. And so it's actually possible, one thing that was found in that kind of high profile study that we are talking about is the dose to the heart actually was a little bit lower with the protons. But that didn't translate into any difference in patient longevity. So, not every small incremental difference, that we might be able to calculate would actually have a meaning for a patient. And so without that benefit in the clinic, is that enough to say to a patient who has lung cancer, you know, we want you to go to a totally different city for 6 weeks to have your treatment, to be away from your support system and things like that, that probably doesn't make a lot of sense for the average patient that you might see.
So at this time, for a patient who may be told that radiation therapy is not an option because of the location of the tumor, wherever that may be, should they investigate further, or we just don't know enough yet?
Well, so it's rare that a radiation oncologist will give you an absolute no, that, you know, something is too close to a given structure that they just can't do radiation. It can happen, but oftentimes what we're faced with is just doing a little bit less radiation in that situation. If we think radiation is important, proximity to important structures doesn't usually stop us from delivering some therapy. It just might curtail the total amount that you can deliver. What I would say to that question is, because that you know, it's a little bit general, so it encompasses a lot of different situations people might face. Is I would say talk to the radiation oncologist who's treating you and ask them that question directly. You know, would protons help? Is there a role for a therapy like that? Would that help a radiation oncologist do a better job in treating my tumor? And there are certain situations where the answer to that question might be yes, but it's not. That's not a very common situation that we face.
Yeah, so that was a perfect answer, because I think what I was trying to kind of pull out of you, and you nailed it, was at University of Colorado, and like, you know, academic centers and large community centers around the country, this is what you can expect. But it is also pointing back to why it's important that your physicians are specializing in your disease, because in a very small community center in a rural area where a radiation oncologist is treating whatever walks in the door, right? Regardless of what kind of cancer this person may have, they might not have the benefit of the expertise that Dr. Rusthoven has and what he's talking about when it comes to radiation care. 80% of patients are seen in the community setting, right? So 20% of the patients have the benefit of access to teams like this. So it's important that, again, I'm pointing back to meetings like this, to be able to reach patients who don't have that access, so that we can help them to engage in this conversation with their physicians. And with that, yes, please.
Since you're talking radiation oncology, could you explain to patients why sometimes they can have stereotactic radiation and in other times it's not possible? Because that comes up a lot in the patient groups.
Sure. So first, just for people who aren't familiar with that term, it's probably good to define some of the terms in the question. So stereotactic radiation is kind of a buzz term. It's one of the kind of the newer technologies that we've developed in the field of radiation oncology, not just at the University of Colorado, but the field has developed this technology and brought it to the clinic within the last decade and a half. It's become more mainstream. And so stereotactic, actually, what it's usually referring to is very focused treatment to a higher dose that's delivered in typically maybe 1 to as many as 5 treatments. And then you can blur those definitions a little bit, and sometimes we'll still refer to things as stereotactic radiation up to 10 treatments. So it's usually a pretty short course with, again, focused high-dose treatment. And there's a number of indications for treating tumors that way, but if you just wanted to kind of do it in broad strokes, what you could say is, if you're going to deliver a focused high-dose treatment, you have to have a very well-defined target. And it has to be not too large, because if you're delivering a high dose of radiation, if the area is too large, you start to worry about causing side effects or affecting other normal tissues and organs that the tumor may be close to. So common scenarios where we use stereotactic radiation, one of the scenarios is actually early stage lung cancers. So if someone has a stage 1 lung cancer, typically that means they have a very well circumscribed, well-defined target that we can treat without any lymph node involvement, and they don't have cancer in other areas of their body. So we're focusing on a well-defined area, and so we deliver a high dose of radiation in a very precise fashion to that spot with the hopes of eradicating and getting rid of the tumor for the rest of the patient's life. And then, interestingly, the other scenario where sometimes you'll encounter very well-defined targets is actually all the way on the other end of the spectrum, which is stage 4 cancer. So in patients who have actually developed metastatic disease, they may be getting, I'll just use an example. So you may have a patient with ALK-positive lung cancer who's getting a targeted therapy like alectinib, and they're doing great. And then they get a new set of scans, and they have 1 brain metastasis that pops up, or 2 brain metastases. And they're very well-defined targets, and there's a clinical reason why we want to treat those with a high dose of radiation to get rid of them, because we want to keep the patient on this well-tolerated drug, and we want to get rid of the problem spots. So that's another scenario where you would use stereotactic radiation to try to get rid of those areas completely. Then, I just gave some examples of stage 1 and stage 4 cancer, but then there's a lot of things that can happen in between where we might think about doing radiation. So in lung cancer, if a patient has a stage 2 or a stage 3 lung cancer, that may mean—
Explain what that means.
Yeah, that may mean that they have a primary lung tumor, and then they have lymph node involvement. And so lymph nodes are normal organs that we all have throughout our body, but they're common places for cancers to go, and they often help us define the upstaging from stage 1 to 2 or to 3. And so in lung cancer, if you have stage 2, that often means that you have a lymph node that's involved in that side of the chest, and then stage 3 can be lymph nodes in the center of the chest, would be kind of a broad way of describing this. So if I'm asked as a radiation oncologist to treat all of those areas, and we're trying to get rid of the tumor and eradicate it and help the patient live cancer-free, then I have to treat a much larger area. And so in order to do that safely, what I actually have to do is do small doses of radiation each day over several weeks. And so what I'm hoping to accomplish with that is I'm killing cancer cells with each of those treatments. And that they may cause a little bit of irritation to the normal tissues in that area, but not so much to cause those tissues to have dysfunction. So permanent swallowing dysfunction, or permanent cardiac heart dysfunction, or permanent lung dysfunction. So by doing a little bit each day and allowing for the recovery that happens between those treatments, I'm able to treat much larger areas and still get to doses that are able to eradicate the tumor. So a lot of what so that's a kind of a broad tour through how we think about these things, but if I had to summarize it, it would be that if you have a well-defined target that's not too large, a lot of times that can be amenable to stereotactic radiation. And then you have to ask, is it helpful to the patient to try to treat this with a high dose to get rid of it forever? Does that provide some sort of advantage for the patient's quality of life or oncologic outcomes? And then as things get larger, we start to become more conservative and treat with a lower dose of radiation each day with repeated treatments.
So I have one more question, and then I do want to move to Dr. Eisner to go to step further back and talk a little bit about molecular pathology, what that looks like. But you touched a little bit on the oligometastatic sort of aspect of this, and I think it's an important topic. So if you could explain that a little bit further. You did a good job. It was quick.
Sure.
To everybody, that would be great.
Yeah, so oligometastatic disease, that's another kind of buzzword that's, it was actually introduced, the term itself was introduced in the 1990s, but it didn't really catch on until probably the last decade. And oligo, if I'm not mistaken, it's Greek for few, so few metastases. And so when we talk about a patient with oligometastases, we're talking about a patient with few metastases, a very small number, usually that you can count. And the classic definition is 5 or less, but there's no real hard definition from a biologic standpoint. There's nothing magical about the number 5, but in general, the fewer metastases, the better. And so in this group of patients who may have stage 4 metastatic disease but have a very limited burden of disease, there are certain situations where that might influence how we treat them. So historically, once cancer became metastatic, stage 4, the classic teaching, even when I was in med school, was that the only appropriate therapy was medical therapy, chemotherapy and things like that, to try to control the disease for a certain amount of time. And then local therapies, and by local therapies I mean things like radiation or surgery, were reserved for addressing symptoms. So if someone had a spot that popped up in the bone that was painful, well, that would be a good reason to use radiation because that's affecting their quality of life. We'll treat that with some local therapy, but that's not part of the big oncologic goal to help improve longevity for patients. But that kind of thinking has really changed quite a bit. And so now instead of thinking about this kind of all or nothing paradigm where you have metastatic disease or you don't, we're treating for cure or we're not, we have started to kind of key in on this group of patients who have a limited burden of metastatic disease, where we actually think that doing local therapies to try to eradicate all of that disease in some patients can be very helpful and can help patients improve their longevity.
So it basically allows the patients to stay on whatever systemic therapy they're on, be it chemo or targeted therapy. Yes. Please.
Okay, so I'm going to be the purist here. Okay, so we're getting a little muddled with some terms here. So oligometastatic is what you walk through the door with, and I actually think the definition is less than 5. And if you remember, Janet, you remember we got involved with that group that were trying to change the NCCN guidelines?
Yes, for oligoprogression.
No, for oligometastatic at the beginning, because so oligometastatic, you walk through the door, and it's the concept of like the one that got away. You know, you have your cancer, and then you've got one spot somewhere else that gets your toe into the water of stage 4. And the NCCN, National Comprehensive Cancer Network, which is some of the kind of guidelines that come out there, used to say if there was a solitary metastasis, then you could be more aggressive in the treatment using the kind of things that Chaz just talked about. But they literally, the original iteration, if you remember, said such as a solitary brain metastasis or adrenal metastasis.
And those were the only choices.
And those were the only two they said.
Yeah.
And so, Janet, you probably know the story, but I don't quite know how the kind of, the patient pressure group got involved.
That's fantastic.
But they bullied us into...
When we were bullies.
Yeah, well, not nicely bullied. So I was sitting on the NCCN panel then to say, well, hold on, that's stupid. Let's think outside the box. Why do we care if it's just because somebody's published on the adrenal gland and the brain? Well, what if it was in a lymph node or a bone? And so the change in the wording was really simple. It just said, limited sites of metastatic disease, which didn't say it had to be 1 or 2 or 3, and it didn't say it had to be in this anatomic structure. But that just gave us the freedom.
It gave the community oncologists the permission to go after those treatments if it is somewhere else other than the brain and adrenal gland.
Do you remember how the bully group started?
Yeah, there were a group of patients online in Inspire who were dealing with oligoprogression or oligometastatic disease, and we were pulling up all of these articles and realizing there's a lot of literature out there saying that this is possible. And we wanted to see the guidance change because some of the doctors wouldn't treat it if it wasn't in the guidelines. Yeah. So we started sending you lots and lots of articles.
And then there's the other example, which is oligoprogressive disease, which is where I think you're coming from. And that's a term that we invented from Colorado back in about 2012, which is exactly the same logic. So if you say, look, you walk through the door and you have one spot that got away, you're going to treat it more aggressively. What if you were on a targeted therapy? And sure, you started off with 50 and 49 are asleep, and then only 1 wakes up. Isn't that the same logic? Couldn't you treat that one spot aggressively and stay on the same therapy instead of panicking and having to change the other thing? And so when we first started doing that, so Brian and I did that, everyone thought we were crazy, and now
weeding the garden is very popular.
Yeah, weeding the garden is very popular. They probably still think we're crazy, but they don't say it to our faces anymore.
But when does weeding the garden, and when does it just become whack-a-mole and no longer like an option?
Well, I mean, you can have the same conversation with any gardener. I mean, it depends. If you go out there and you're walking up your garden path and there's one weed, it seems like a good idea to pull it up. If there's 50 weeds, even if you spend the whole day pulling up, tomorrow there's going to be more weeds. So there's a law of diminishing returns. But again, it's not just about, failure isn't, and something came up on the next scan. You have to go, well, what's the alternative? Could, constant, people die from uncontrolled cancer. Sure, there comes a point where it's futile if it's 50 every single time, but if they just come in ones and twos, then that's feasible.
It's managing disease.
Yeah, I mean, it's fuzzy about what the criteria are.
Before we move on, does anybody have any questions in this radiation? Yep.
I'm very involved with the ALK positive support group. We've got about 1,200 members, and I'm pretty conscientious about reading probably every post that everyone does. And there's been quite a lot of conversations about SRS for brain metastases, and rather than even talking about 3 or 4 or 5, they're talking about even when there's 10 or 15, but it's still a better option than whole brain radiation. And it might take 2 or 3 sessions of the SRS, but you end up with a better long-term result than the damage that comes from whole brain radiation. So just interested on your thoughts on that, if you were the patient in that situation yourself.
Yes, so SRS is an acronym for Stereotactic Radiosurgery, and there's a couple places where we use that term, but the most common place is in the brain. And in the setting of lung cancer, it's when we're treating brain metastases, so when the cancer has spread to the brain and we want to treat that. Stereotactic radiosurgery is, it's a similar principle to the stereotactic radiation that I was describing earlier, which is focused high-dose treatment, just on that spot, trying to not treat anything else, and doing our best to eradicate the disease in that area that we're treating and minimizing side effects. So that's a very viable way of treating brain metastases. The other common way of treating brain metastases is with something called whole brain radiation, which is kind of like what it sounds like, which is treating the entire brain, usually with a low dose of radiation repeated 5, 10, or 15 times. And so that's treating not only the spots that you see, but also hopefully addressing microscopic disease that you might not be able to pick up on an MRI, but could be there and might manifest as brain metastases down the line. So why pick one versus the other? Stereotactic radiosurgery is probably a little bit better at getting rid of the spot that you're treating, because it's a biologically higher dose, and so the control outcomes on the individual tumor is a little bit better. Whole brain radiation, like I said, it can address microscopic disease, and so it can be a little bit better at preventing new spots from popping up on the next scan and the need for further treatment than radiosurgery. The big drawback of whole brain radiation is that, and this has been shown in a number of randomized trials, that there are some cognitive effects of this treatment that can show up as early as 3 months, but are also still present in patients who are alive at 6 and 12 months. And so if you do very rigorous cognitive testing where you test people's memory and attention and concentration, you can see a greater decrease in those scores in patients who get whole brain radiation that you don't see quite as much with radiosurgery alone. And there can be effects on patient-reported quality of life and things like that. So that's radiosurgery and whole brain radiation. And then you get into the whole debate about the number of lesions that you can treat with radiosurgery. So the reason that there's this magic number of 3 or 4, where classically and in guideline statements, they'll say, well, radiosurgery is a very appropriate treatment for limited brain metastases, classically defined as 3 or 4. And it's not because that number is actually magical and something specifically bad happens when you get to 4 or 5. It's because those were the inclusion criteria for the studies that support doing radiosurgery. That's just all they were comfortable doing, and these studies were launched in the 90s and early 2000s. And so there's nothing to say that radiosurgery couldn't be appropriate. And so what we've seen now in the aftermath of those studies, and now that radiosurgery has become common for 3 or 4 brain metastases, is a lot of big centers that do this type of treatment off trial are starting to offer radiosurgery for more and more metastases, and they're starting to report their outcomes. And there have been also some prospective trials that have suggested that, well, if it's good enough for 2 to 4, it's also about the same for 5 to 10 and more. And so that is something that we've published on, actually specifically in this situation. Last year we published our outcomes. Ross and I were involved in that, and one of our very talented residents published that, Tyler Robin, where we looked at what our outcomes were specifically for ALK and EGFR patients when we treated them with radiosurgery alone for 4 or more metastases. And what we found is that their outcomes were quite good and comparable to, in terms of patient longevity, to outcomes with whole brain radiation, and also very similar to outcomes with doing radiosurgery for less metastases. That's very encouraging because it helps support kind of this growing story that, hey, you know, if we're trying to improve patient quality of life, maybe doing radiosurgery when we can is the way to go. And the other interesting thing about that study was that one of the common reservations that radiation oncologists in the community might have is, well, if I'm treating 5 or 10 or more metastases with radiosurgery, doesn't that kind of become like whole brain? Because you're treating things all around, you know, isn't the dose kind of starting to become similar to whole brain? Can't you expect the cognitive side effects to be similar? And so we actually did those calculations. It was actually Ross's idea. He said, well, why don't you look at what those doses actually are to these important structures in the brain that are associated with memory. And they were still, even when we treated 15 or 20 metastases, they were incredibly low with radiosurgery, which I think helps to start address this reservation that oncologists have that, no, it's not the same as whole brain radiation. It's its own thing. It's very specific, and it's a reasonable thing to do in certain patients. And so opinions vary on this, what the right number is, and that is kind of getting into the art of medicine, which is how comfortable is the radiation oncologist? Is the radiation oncologist and the medical oncologist willing to follow things closely and get MRIs and make sure that they're staying on top of these, of anything new that pops up? Does it make sense in terms of the patient's overall clinical picture? You know, is it consistent with their goals and what's going on with them? And so that is still being defined, and there's new studies looking at doing this for more and more spots for patients. But it's an area of active research, and it's something that we've been very interested in as a cancer center.
So there's so much. So when there is a patient who you can't spot treat, just to make it simple, and they do need whole brain radiation, who qualifies for Campbell sparing whole brain radiation?
Okay, gotcha. So every question has so many.
Do you want to explain what the hippocampus
is?
Yeah, so. And then is that Greek? Yeah. Is that Greek or Latin? I think that's.
I don't know.
We've got plenty of time.
Yeah. So the hippocampus is an anatomic structure in the brain. We have one on each side. It's part of this overall kind of deep brain structure.
Do you know what it means in Greek?
I don't.
It means seahorse.
Seahorse, because it looks like a seahorse.
And I just want to clarify that I'm asking
looks like the tail of the seahorse.
Because patients that have been living with lung cancer a long time know that lung cancer likes the brain. So it's a concern for everyone diagnosed with lung cancer.
Absolutely, yeah. So it does in fact look kind of like a seahorse. It's this kind of round shaped thing that's on both sides of the brain. And it's a very important structure in memory and concentration. And so there's been interest, historically, just to give you some background, when patients had whole brain radiation, the planning is pretty simple. You're trying to deliver a uniform dose of radiation to the entire brain so that you can address spots that you see, as well as any microscopic disease that could be in the brain as well. Well, the hypothesis is, well, what if we try to treat the whole brain, but we lower the dose to this one important structure on both sides of the brain that's involved in memory and concentration? And that structure of choice was the hippocampus. And so there have been some prospective studies that have looked at doing this. The data is still evolving. So where we're actually at with that data, primarily, there was a single-arm study where everyone received this therapy, and then they looked at their cognitive outcomes in terms of the refined cognitive testing, and they looked at those outcomes and they compared them to historic controls. So they looked at other studies where they had gotten that data, and the outcomes looked good and promising enough to do this in what's called a randomized trial, where half of the patients get whole brain radiation for their brain metastases, and half of them get hippocampal avoidance radiation. And those studies are still ongoing. And so we actually don't know if that therapy is going to end up being superior. There's good reasons to be optimistic, but it's actually not a component of the standard of care yet until those studies get published and people on these guideline panels have time to review that and decide if this is the right thing. So there are still places around the country that offer this off trial because people are trying to do the best for their patients, and then there's other places where you may actually be able to be enrolled on these trials and be treated this way. But that's a long way of getting to. We don't know. That data is still being developed, and but it's forthcoming, and it'll be very interesting to see what it shows. Yeah.
So everybody who's worried, be on the lookout for that. Yeah. I'm going to turn the mic over to Michelle. She has some questions from some people online. And then I promise we're coming up.
We're saving Dara's voice.
We are, right?
Yeah.
So, someone was asking if it's possible to have proton therapy in a spot that has already had IMRT.
Short answer is it's possible. So the question is really getting at something called re-irradiation, which is a fancy term for radiating the same spot twice. And so that can be done, and we do it sometimes. You could do it with protons, or you could do it with X-rays, like I had talked about before. It just, the concern is that the risk of side effects, depending on what you're treating, can go up the second time around. And so that's a decision that has to be made very carefully between the patient and the radiation oncologist and potentially the rest of their team to decide if those risks are acceptable.
But do you think that's a potential? As we were talking about it earlier, I was thinking, is that going to be a special kind of niche indication for proton therapy? That kind of re-irradiation where the normal tissue's really got a bit of a dose, and that exit dose may suddenly become very important.
Yeah, I mean, I think that's a reasonable hypothesis to say, well, this is a special population where lowering the dose to the structures in the immediate vicinity of an area that's been radiated before is maximally important in this population, and this is a population where we really should do research to figure out if there's an advantage of protons versus X-rays. The short answer is we don't know, and that's also a pretty heterogeneous population where the situations where one might consider doing radiation the second time around really can vary widely from situation to situation. So it's hard to give a blanket statement that yes, protons are good for that or not. It's very individualized.
I mean, I can imagine a situation where you've given radiotherapy and it just didn't work, and the stuff grows really quickly. That sounds like you shouldn't re-irradiate because radiation's not an effective therapy. Versus it does amazing, and then 2 years later, then it starts to grow. And so kind of the devil's a little bit in the details.
So the other question is, if stereotactic radiation has already been done, is surgery the next best option for one tumor coming back, even while on alectinib stage 4?
So that is highly individualized. So it kind of depends on where the location is. It's not totally clear from the question if what structure we're thinking about re-irradiating. It could be the lung, it could be the brain, it could be another organ. So it really depends. I mean, there are situations where we've treated brain metastases and they've been controlled for several years, and then, they start to come back a little bit, and we think about treating them again because we think that, well, that might be an easier a better tolerated therapy than having a brain surgery for that spot. But there are other instances where the surgery might be the best treatment, and so that's something where having a good conversation with the treating oncologist about the options and the pros and cons, and maybe visiting with the specialists, so visiting with the surgeon, visiting with the radiation oncologist, and then also getting your medical oncologist's opinion about the best thing, I think will be really important.
Do you want to touch on radiation necrosis as a potential? I mean, if this is in the brain, whether radiation necrosis could be misleadingly looking like progression, and what it is?
Sure. So when we treat brain metastases, specifically with stereotactic radiation, there's a number of outcomes that you can see on subsequent MRIs. The best outcome, and the one that makes us feel the best, both the doctor and the patient, is when the tumor just disappears. So that's great when that happens, but it doesn't always happen. Sometimes the tumor shrinks, and what you're left with is something that you presume is probably scar tissue, but you can still see it on on the MRI, but it gets smaller and it stays controlled for all the MRIs that patient has in the future. And so that's another pretty reassuring situation. The part where it gets a little bit difficult is when you treat a spot and then maybe it's controlled for a little while, but then it looks a little bit larger and has a little bit more swelling around it 6, 12, 18 months down the road. And there's two possibilities you could be dealing with there. Obviously, what the patient is typically most concerned about is, well, did the cancer come back? Did we not get all of it? And that's a very valid concern. That's one of the primary things that the oncologist is thinking about as well. But then there's this other thing that we call treatment effect, or sometimes called radiation necrosis. Necrosis just means dead or dying cells, but they can cause swelling. And it can actually look a lot like recurrent tumor on a brain MRI. And it's actually an area of a lot of research, and it's not always that easy to tell for clinicians what you're dealing with. And sometimes the ways that we figure it out is with the test of time. You have something that looks kind of suspicious, but you keep an eye on it with subsequent MRIs. Maybe it doesn't grow anymore, and then you say, well, that is most consistent with probably treatment effect. Whereas if it continued to grow, we'd be more concerned about tumor. Sometimes if the patient's having symptoms, you have to do surgery, and then that gives you the final answer, because a pathologist will look at it under the microscope and say, this is treatment effect, or this is cancer, and then you know for sure. And then there are a number of other ways that we think about things. Sometimes we look for increased blood flow that might be consistent with cancer with some special MRI sequences. But that's a question that's really tough, and it challenges radiation oncologists and radiologists, where we will sit down and look at things and say, it could be either, we just don't know, and you have to live with some uncertainty in some situations.
So Bonnie was online and also had a question, but it's actually a broad question, so we're gonna save it till after we've gone through a couple of these other areas, because I think it'll be more relevant then. And with that, I want to go to Dr. Eisner, whose job it is to ensure that your treating physician knows exactly what your cancer looks like and how to treat it. So, Dr. Eisner, can you tell us a little bit about what you do?
Sure. So I feel like I need to talk both about pathology in its traditional kind of classic sense, as well as molecular pathology, which is kind of the new frontier of pathology. So pathology in the classic sense goes back to the days of Anton von Leeuwenhoek and his microscope. And really, microscopy has gotten a lot more sophisticated in terms of the optics, but the idea remains the same, which is we want to look at things under the microscope to try to characterize disease. And what I do know, because I've heard this from many people, is that there's this big black box. I had a biopsy, and I'm waiting for pathology, and it's going to come back, right? And what happened between that biopsy and the report is something, and I'm not entirely sure what that was. So I'm going to try to explain it to you, usually a little better done with pictures, but whether it's a biopsy or an FNA or a full resection of some sort. Sorry, FNA is a fine needle aspirate, which is similar to a biopsy, but is a little bit less invasive in the sense that a very small needle is used to pull back and basically by negative pressure suck cells out of a lesion. And so regardless of the methodology you use to get tissue from a lesion, a pathologist's job is to look at that tissue under a microscope to characterize, is it normal or abnormal? If it's abnormal, what is the nature of the abnormality? And while a lot of what I do is about describing the nature of specific cancers, see, waiting really did help.
It did.
There's the whole entire spectrum of everything that could potentially impact a tissue. So cancer is one of the things we think about, but we also think about infection, inflammatory diseases, lots of different things that can lead to an aberrant imaging or clinical symptoms that leads to a biopsy or an FNA. Now, you go, okay, that just tells me that you look at a microscope. You just said the same thing. How do you do that? Well, really what we do, and I'm going to talk more about a biopsy here, is we take that piece of tissue and we put it through some very fancy machinery where the goal of it is to essentially desiccate it into something that's much harder than the tissue you might just be able to touch and feel. So if you've ever been to see exhibits that were popularized 15, 20 years ago, Bodies.
Body Works?
Body Works, Bodies in Motion.
I refuse to go and look at those. Like, gross me out.
It was amazing. We know where you were during your anatomy class.
Yeah, squeamish. Yeah.
I was trying to avoid my anatomy class, so it's shocking to most people that I'm a pathologist if you were in that anatomy class with me.
You're a late bloomer. Yeah.
Exactly. So if you've ever seen the Bodies exhibits, you know that that's a sort of plastinization, and we do something very similar with tissue. We take the tissue and we desiccate it, and we use a lot of chemicals, and at the end, when all of that is said and done, a piece of tissue, which is normally squishy and very deformable, and if I did this to it, I would make it hard to recognize, gets made into something quite firm. And then we embed that in a piece of wax, and we essentially slice that piece of tissue on what amounts to a super mini deli slicer. And we cut tissue at 4 or 5 microns thick, and we can then put it on a slide.
How thick is a micron?
How thick is a micron?
Yeah, don't nerd out on me. What's
about a hair, right?
Well, I could give it to you in fractions of a centimeter.
Yeah, give it to me in fractions of a centimeter.
A micron is 1/1000th of a centimeter.
Okay.
Small.
Yeah.
Yeah. Small, very small. So we then stain that tissue and we can look at it under a microscope. And it's through the training of spending a lot of time with my eyeballs in a microscope that I can say that cell's normal, that cell's not, right? And we basically are experts at pattern recognition. We look at a whole cast of patterns, and diseases tend to cast themselves in patterns. And cancer is one of the different types of patterns we can see under a microscope. Now, you might have heard about immunostains, right? The tumor was positive for this and negative for that, and it turns into this crazy alphabet soup. It was positive for CK7, TTF1, and negative for, right? This is highly technical stuff about how cells differentiate, and the fact that some cells, when they differentiate, turn on some things and turn off other things in terms of their genes. In short, what we can do is we can take those super thin sliced sections, we can put special antibodies on top of them, and then we look for where the color indicated that antibody was sticking. So for example, TTF1, very common marker in lung cancer, I look for, is there color in the nucleus of these tumor cells, right? It's important because if there's color all over the tumor, the tumor cells, is not the same as it being in the nucleus of the tumor cells. So for every stain, I kind of have a mental Rolodex. This stain's supposed to look like this in these cells. This other stain's supposed to look like this in these other cells. If it looks like this in this cell, then it doesn't belong there, right? So it's this pattern of what belongs and what doesn't belong that allows us to characterize tissues as normal or abnormal using those stains. And it also allows us to characterize, this is a tumor that came from a lung origin versus this other tumor came from a colorectal origin versus this other tumor is a lymphoma, right? And that's how we're able to do those things both with how the tumor cells look in the microscope and with those immunostains.
Can I ask a question on
Yes,
that really
of
quick?
course.
Because there's a common misunderstanding with patients who maybe have a spread of their disease down the road where they think they have a different cancer because now it's in the brain or now it's in the bones. Or like, oh, it's not bad enough, I have lung cancer, now I have bone cancer. So can you explain that it's not really bone cancer or what that means?
Well, I can't exclude that for you completely until I look at it. So that's actually really the point, is that when we think somebody has a metastasis to a distant site, the gold standard is to do a biopsy or a fine needle aspirate and look at it. And I can tell you whether it's the colon cancer that metastasized to the lung, or if it's a lung cancer, in part because of how the tumor cells look, but in large part because of those immunohistochemical stains. So, for example, if I get a bone biopsy and it has all of the features of a lung cancer, and more importantly, it stains like a lung cancer, that's not bone cancer, that's lung cancer that has metastasized to the bone. And that's a lot of how we handle those things, is we look at a specific case. The ideal situation for me is I have a case in front of me, and I have the same case, or I have the patient's tumor from 3 years ago at my institution, and I ask the archivist, hey, deliver the slides from 2015 to me, please, and I can look at them at the same time and say, well, look, they look very similar. And that's something that we actively do, right? Did it just this morning. And so we can make that distinction of this tumor is almost certainly a metastasis of this previous tumor based on how it looks and how it stains. Or we can look at a tumor and say, gosh, you know, something looks a little bit different here, right? And that's a big part of my job as an anatomic or surgical pathologist.
What if you have something that says it's poorly differentiated?
Well, poorly differentiateds are difficult, right? But generally speaking, even poorly differentiated tumors tell us something about them, right? So
Can you explain what poorly differentiated means?
Sure. So when we talk about tumors, classically we talk about how differentiated they are, meaning how much does this tumor look like and looks like it's trying to emulate the organ it came from, right? So I can tell you what a colon looks like normally. I can tell you that a colon cancer often looks like a somewhat deranged version of what the colon looks like normally, right? If I can still tell that it kind of sort of looks like colon, that means it's well differentiated. That means it's trying to mimic the biologic function that those cells arose from. But tumors don't always do that, and particularly as they acquire genetic alterations, they can lose some of those features that allow them to do things like form nice glands that look like their parental organ. And as they lose those features that look like their parental organ, we call them less and less differentiated. So something that's moderately differentiated is, you know, I can sort of recognize where this came from. It's not really doing that great of a job of mimicking it, but I can still sort of see it in there. And a poorly differentiated tumor essentially means I really think this could be from anywhere. And in those situations, those immunostains become really important, because those immunostains help me to say, well, here I have a tumor that looks like it could be lots of different things, but if it's TTF1 positive, and this patient had a TTF1 positive tumor in the past, that tells me almost certainly these things are related.
So moving beyond that, once we determine, or you determine, what you're looking at, that this is, in this instance, a lung cancer, what next? What are you looking for after that?
Well, I think one of the things that's sometimes not apparent to people is, while some pathologists sort of get cases delivered to them, and there's a stack of cases, and you're looking at the slides, and you're reporting what you see on the slides, that's really just a very narrow slice of pathology, right? And if I work where I only report out what I see in the slides, I'm sort of missing the opportunity to be what I was joking with a friend earlier today is a diagnostic integratician, right? A lot of my job is diagnostic integration. And really for me, so much of the reward of the job isn't that, gee, I know what this is because I learned how to recognize it. It's, I looked at the patient's record and this helps make the whole thing make sense, right? I want to help make the picture make sense. And so depending on at what point in the process I'm seeing a pathologic sample, if it's a diagnostic biopsy, particularly in lung cancer, my #1 priority is how do I get to a diagnosis of lung cancer while maximizing the material for the molecular testing I know we're going to need, right? If it's a staging case, if it's a resection for early stage lung cancer, my priority is how do I make sure that the physician or physician's assistant who was at the bench looking at the specimen took all of the pieces properly so I can arrive at the right final pathology stage, right? Yet again, in a different situation, which is a very active area of research for us, for patients who are on targeted therapy and experience a progression on therapy, oftentimes we want to biopsy those lesions so we can try to understand what is driving that progression, right? And that's yet a different mindset for me. What does this look like now? Does it look mostly like tumor response? Does it look mostly like necrosis? What does this look like, and how does that integrate into what I know about this lesion and this patient's past care? So that's kind of the pathology piece. Yes, go ahead.
I don't want to interrupt, but I want to stop before we go further, because a lot of times patients, again, will call with, well, you know, they did the biopsy, but it was necrotic tissue or it wasn't good quality tissue. Can you talk a little bit about heterogeneity and what that means and
Absolutely.
how that's a challenge?
So when you think about a tumor on an X-ray, it looks like something round, right? But in real life, it's a three-dimensional thing, and it's not necessarily globoid shape, right? It can have weird shapes. It can have little tentacles reaching out.
Did you say globoid?
I did say globoid.
Is that really a word?
I don't know.
Okay. do you mean global?
No, I don't mean global.
Okay.
And when somebody goes to biopsy something that is otherwise a three-dimensional object, you're sort of taking a guess, right? And interventional radiologists are very good at saying, well, I can tell from the CT scan that the center of that's necrotic. So I don't want to hit the dead center. But if I hit too much on the edge...
In both senses of the word, dead center.
True.
Because the center is often dead.
I don't want to hit the absolute center. At the same time, I don't want to get all the way over to the edge, because sometimes at the edge of these lesions, we don't actually see the tumor cells. We see the body's reaction to the tumor cells. So the interventional radiologist is doing everything they can to target the needle to the right location of the lesion to help me be able to make sense of what has been sampled. But it doesn't work all the time, right? So either because it's too hard to appreciate that some areas of the lesion are necrotic, or because the necrosis is distributed in a way that it doesn't stand out radiologically, or because a needle, a teeny tiny little needle, even though you have a largish target, can be pretty hard when you're going through a person's body and they're breathing and you've got fluoroscopy on, and it's a very delicate dance. And so oftentimes we'll get a biopsy, and I might get a biopsy that's got one little edge of tumor off to the side and the rest of it's all necrosis. That doesn't make it any harder for me to make the diagnosis. I have that little cluster of viable tumor cells, but it'll make it a lot harder for me to get the molecular characterization off of that lesion.
If I can just give an example, the last time that I had a multidisciplinary tumor board was after I'd had treatment and I had a new tumor or something come back, and they did a biopsy of it, but they didn't get any tumor tissue. And the board had to meet to figure out, is this a recurrence of the cancer or is this just a response to the treatment? So.
Right. So a lot of times, particularly in the setting of post-treatment, when I get a biopsy, what I see is a lot of fibrosis. What is fibrosis? Fibrosis is the body's reaction to an injury of some sort. So if a cancer has been effectively treated and now the tumor cells are necrotic, there's going to be some machinery that comes in to clean up, right? And the end result, many months later, after that machinery comes to clean up, is going to be fibrosis. And so I often see fibrosis post-treatment. Does that mean the lesion is only fibrosis? I don't know. Does that mean that there couldn't be a teeny bit of tumor hiding in the fibrosis? There sure could. So this is a big part of the guesswork of heterogeneity, and it plays a particular role in some of the markers we look at today. So for example, PD-L1 immunohistochemistry is a big thing right now for immunotherapy. But if I only have 50 tumor cells out of a lesion, I don't know if my characterization is necessarily representative of the whole lesion. And that's an area of very big research. What I will say on that, though, is that when we think about drivers of cancer, ALK, EGFR, ROS1, we tend to think of these as trunk events, right? So I don't worry as much that if I got a small, difficult biopsy that I will miss an ALK or a ROS1 or an EGFR, because we think those tend to be more uniformly distributed among the tumor cells. I'm not going to be absolute about it. I've learned too many times that if you try to be absolute about cancer, it teaches you you're wrong. So most of the time, we can say, well, we didn't find an EGFR mutation in this very small sampling. That's highly indicative that the rest of the tumor also does not have EGFR, right? So is that the segue to molecular right there?
Well, can I just throw one thing out, which is what I really like seeing is, so Dara's not talking about a disease. She's talking about a disease which isn't just in a patient, but is in a person. So she's describing, you know, together when we're sitting together, she's looking at the scans because the scans are of a person. And when we're all talking about these things together, you know, nobody is in a silo. We're all, you know, if it's you or your mom or your dad or your kids, you know, they're treating the person. And I think that's incredibly important to always remember.
I couldn't agree with you more.
Yeah, us pathologists have reputations for being antisocial, hide behind the sofa, I don't want to talk to you people.
And you're not. You're the complete opposite. So Dara knows the name of the patient, and she remembers the history. And if I say, you know, they've traveled from Nebraska and they got 3 kids and a dog, she'll know that too.
And I think the challenge there is that the patient doesn't know that, right? Because the patient's the ones with the perspective that the pathologists are somewhere down in a cave, and hopefully the tissue gets from whoever took it down to where they are.
Sometimes they are in a cave, and sometimes they don't speak. But in the same way that, you know, I page Chad, Dara pages me. It's like, oh, there's Dara again, you know, saying, so tell me about the story about where did this biopsy come from? I mean, she's the kind of bloodhound who's going to try and search out, you know, the story too. What did you call it? An integrative diagnostician.
Yeah. I was actually very surprised. The first time I met Dara was at ASCO when I came up to a poster from the University of Colorado, and I introduced myself. She says, "Oh, I have your slides on my desk."
But again, that kind of points back to the treating physician having that conversation with the patients. Otherwise, the patients don't know, right?
Right.
You didn't know that.
I didn't know
who Dara was or what, right?
Right.
So I do want to move it a little bit into, not a little bit, a lot of it into sort of the molecular diagnostics, and I'm going to ask Dr. Kamich to kind of, you two, to sort of share this part of the conversation. Who are you testing beyond, well, does UC Colorado, is it reflex testing for lung cancer patients? If so, for which markers are you looking? What is the difference between what that might look like in a comprehensive genomic profile, and who are you testing?
Well, it's a work in progress. So we established the concept of what we would test for, and you know that's gradually expanded. And then the 2 other questions that we started to apply are we going to only test certain what's called histologies? So, you know, somebody like Dara looks down the microscope and they say, well, they all look like lung cancers, but this came from glandular tissue and it's called an adenocarcinoma, or it came from lining tissue and it's called a squamous cancer. We're only going to test one or the other. And quite a long time ago, I think we decided that even the best pathologist is still human, and that's a subjective determination for trying to decide whether you should do an objective molecular test. And so we threw that out and we said we'd like to test all histologies. And then more recently, it was the question as, you know, if you've had somebody who has a really early cancer and they're probably cured by surgery or radiation, do you need to test that And we kind of, a few years ago, I can't remember how, we decided we were going to test everybody for everything, even though recognizing that sometimes we would never need that information, because we think it's important to kind of lead the field and we don't quite know what we're going to use these things for in the future. But you can probably give the real history behind all of that.
And I thought we stopped testing stage 1s.
No, I think we still do.
I run the lab. I'm pretty sure we don't.
But I think this is
I think we still order it. But okay.
I think this is
Maybe
relevant.
I order it and you just tear it up.
Right. I think this is relevant because Janet and I were having a conversation earlier about the percentage of the eligible population that's still not being tested, right?
Oh, I can tell you when we do stage 1s, when we have 2 in one person.
Yes. Now they're going to have an internal UC Colorado debate.
So we have. So the other thing for, you know, let's say you have 2 spots, one in one lung and one in the other. Is that one cancer that's spread to 2 places or 2 independent events? And that's where the molecular pathology can help to differentiate between those 2 things.
And that's very much a new use of molecular pathology. So I'll talk about that. It's a great tangent. So this is one area where molecular really makes a different kind of difference than the EGFR and ALKs and ROS1s of the world. And we've seen this many times, right? A patient comes in and has more than one lung nodule, or they had a lung nodule from 4 years ago, it got taken out surgically, and now they have a new lung nodule. Well, if these are 2 separate events, theoretically, they could both be stage 1 events. They could both be surgically curable. If they're the same event, one is a metastasis of the other. So we're talking about a distinction across the entire spectrum of staging, the distinction between multiple stage 1s and a stage 4 status. And what we do is we use molecular testing to say, do these have divergent molecular profiles? If the molecular testing says this one has a KRAS mutation and this one has an EGFR mutation, I can be pretty sure those are not the same cancer. That completely changes the therapy for the patient. And we're not talking about targeted therapy versus no targeted therapy. We're talking about surgical treatment versus medical treatment. So it's a very big deal. I will tell you that we do this all the time at our center. I know for sure that I only get paid for it once, no matter how many times we do it.
You do it for the love.
I do it for the love. I absolutely do it for the love. Don't make fun of me.
So this is the issue as to whether or not a patient has a new primary.
Right.
And I know sometimes that's a real question.
Right.
Is molecular the only way to distinguish between the 2?
So in today's guidelines and in today's staging manuals, they give you very complex ways of using your eyeballs in the microscope to say, well, these nuclei look this way and these nuclei look similar, so therefore we think these things are the same. And I think that that has its place, but I honestly think molecular is far better at this. And the payers will catch up to the science eventually, but we've done this over and over again. And it has proven multiple times that what we think in tumor board, looking at somebody's clinical situation, oh, this tumor was 3 years ago, this new spot came up on the opposite side, it's probably something new. Nope, that one's a metastasis, right? We see it the opposite way all the time. Got a tumor in the upper lobe and the lower lobe. These must be related to each other. Nope, they're different, right? My eyeballs cannot do nearly as good of a job as that, as knowing what mutations are in there.
Do you remember the case we had where not only were there 2 things in the same lobe, they were both adenocarcinomas, they looked the same down the microscope, they both had a KRAS mutation, so they both had the same KRAS mutation, but the exact change in the DNA to produce that mutation was different.
Yeah.
And it's only when you drill down to that level of complete and utter nerdiness that, we actually, one is you're
cured. Are you calling me a nerd?
No, all of us. This is like group nerdiness. It's like Nerds Anonymous. Except we all introduced ourselves at the beginning, right? But that, that's the level of obsessive detail that you sometimes need to do.
So who are you guys testing, and when are you testing? So I want to.
I better ask Dara because I clearly don't.
Yeah. Who is being
I always suspected that.
And when is rebiopsy when is it time to rebiopsy a patient and why?
So right now, our paradigm is any patient in which there is any upstage beyond clinical stage 1, we automatically test. So the smallest lesions with no nodal metastasis, we don't test, but everything else we do. That's really only a part of the picture, and it's really kind of an incomplete piece, because if I'm talking about how big the lesion is and whether nodes are involved, kind of by definition, I'm talking about patients who were eligible for surgery. So that's part of, we want to get this information now to have it in our hands later, right? It's a very different question for what do you do when you suspect advanced disease. So one of the biggest questions in how to handle reflex testing in that setting is this whole issue of siloed information. So if I get a biopsy that says it's a lung biopsy, and I look at it and it's a carcinoma, lung cancer, I can't tell from the information I have whether that should be sent for molecular or not, because there's a dozen additional pieces of clinical information I need to know. If it's a lung biopsy, maybe it was a lung biopsy that was taken because the patient's going to go to surgery, right? So what would be the point of my testing on this teeny tiny little scrap of tissue if they're going to go and get a surgery next week, right? Maybe if I look at their scan and I go, oh, it's a 2-centimeter lesion, they're going to take them to surgery, I could be terribly misinformed. They might not be a surgical candidate. So there's all of this additional information that I need to know whether a small biopsy of lung cancer should be tested molecularly. So even though it's a little bit backwards, right now we do have a reflex paradigm in place for resected samples. And what we have in place of a reflex paradigm for small biopsies isn't reflex as much as we all talk to each other all the time.
I want to give the example from this morning.
By all means.
So we had somebody had a biopsy done this morning, a relatively small sample, and the question was, should we test the sample or should we get another biopsy? And half the room was like, well, there's a big juicy lymph node, let's go get a biopsy. And Dara said, well, hold on. I think I can get something from this. Why should I put the person through another biopsy when I can pull something out? And so that again, that's just an example of putting the person first.
But so there's the inverse situation. You need the multidisciplinary team sometimes to look and say, we only got this little bit of tissue, it's not enough to test. How do you decide whether you need to actually go in and get a surgical sample of a tumor to be able to do the molecular testing?
Well, I think, so I mean, in the setting of advanced disease, I believe everybody with advanced disease deserves testing for targeted therapy indications. And where that gets tricky is if the sample is inadequate or difficult to access. So ultimately, there are, pros and cons, benefits and risks that have to be weighed in terms of a surgical approach. There's a newer evolving technology which is commonly referred to as liquid biopsy. Essentially, it's looking for tumor DNA that has been shed into the bloodstream. And the thing is it's great when it works, right? So in the setting that you're talking about, probably the first thing I would suggest is liquid biopsy. Let's see if we can find something. But the problem is that liquid biopsy has a fairly high false negative rate. So if it's negative, you can't stop there. Then you really have to ask the hard question, is this worth a surgical approach?
And do you involve the patient in that discussion to decide whether they're willing to tolerate having surgery?
I personally do not.
I know you don't.
Well, we have to, otherwise you have to kidnap them late at night and do it. So, yeah, you have to involve them in
It's a
the
good thing I'm not staying close to the hospital.
But yeah, I think the days of body snatchers has gone away. But what you do is you say, okay, we need more tissue, and then you have to say, well, where is it feasible and safe to do it? So maybe you can do it by sticking a needle in. Maybe you don't have to go to surgery. Surgery would be kind of like the last tier that you would go through.
But we have done it before, right? So we have had instances where patients do not have adequate tissue for molecular testing. Let's say they have a pleural lesion. That's a surgical approach if it can't get hit with a needle, but it's a relatively straightforward surgery.
To get a sample of pleural fluid.
To get a piece of pleura.
Oh, okay.
Right. So we've done it with pleural fluids, but so, you know, you have to look at this as, well, are we trying to go after a deep-seated liver lesion that would require a big incision, or are we going after a piece of pleura, which can be done with, you know, 2 little porthole needles in the chest wall, right? So there's all of those pros and cons that go into this discussion.
So I want to transition over a little bit into, we talked a little bit about treatment from a radiation perspective. We talked about pathology and why it's important that you have somebody who knows what they're doing looking at your tissue sample. Why is that important insofar as your job and the tumor board's job in determining what might be the best plan of action for that patient?
I mean, the whole field has moved into kind of personalized therapy. And the idea is, you know, one size doesn't fit all on so many different levels. You know, it doesn't fit all. You know, we gave the example of radiation where, you know, just because, you know, some paper is published saying we only looked at adrenal metastasis where we could be more aggressive about it doesn't mean you can't do something else. So the trouble is when you go to medical school, you know, we're very good at getting people in medical school who are really good at memorizing things. So we learn rules, but the rule is only just an aid memoir. It's not all of the knowledge in the world, and so you have to be able to kind of move outside of the box, for example. And so I'm not entirely sure where I'm going with this, but but I think in terms of personalized therapy, you know, that's why we're all trying to come up with a plan for that individual, not just kind of like, you know, cookie cutter. Well, we always do A followed by B. So that's important for the radiation. It's important for the molecular. I mean, increasingly, we don't treat everybody the same. Even when you put somebody on a treatment and it works, then when their cancer squirms out of control, you know, there's more heterogeneity there, which you have to characterize. And, you know, to pick up on your point about, you know, do you ask the patient before you take them to surgery? Then yes, you know, at the end of the day, this isn't veterinary medicine. You know, this is you are treating a person, and they have to be part of that decision-making process. That was a really long-winded answer.
Yeah, no, it wasn't. But I think it's important for folks watching and here in the room to know that this personalized medicine that Dr. Camage is talking about is relevant not only at diagnosis but at progression. At, you know, at a point in the game where it looks like the treatment you're on is no longer working. And you might need to move to something else, right? Which is where Dr. Eisner comes back in as a do we rebiopsy and see what now might be, quote, driving, who's the bus driver, right? Who's driving your cancer?
The other thing I would say, and without getting into all of the technical details of how molecular testing works, if there's any one mantra I have tried to disseminate as widely as I can, and I'm sure Ross can say exactly what is coming next, it's that no test is perfect, right? And the idea that there's any one way to test that's better than every other way is really kind of an anathema to me, right? Every test has its pros and its cons. Every test has its Achilles heel, right? And I've got a great example from this last week where this is a patient that I was consulted on from California. They said, well, you know, we sent it for ALK and ROS1 and EGFR testing to a commercial lab. The FISH assays for ALK and ROS1 came back negative. Somebody said they thought this might be a slightly different type of cancer called a mucoepidermoid carcinoma. So we want to look for this other fusion. So we want to look for that. So we're going to send it to this big company that does several hundred genes. That company came back, and their answer was ALK deletion, right, of specific exons. Well, that's weird. I've never seen that before, right? So I ran it on a completely different type of test, and I found an ALK fusion. Now, I'm not saying my test is better. I'm saying my test is different, right? And every test has an Achilles heel. And I can go back and explain where the less precise result came from in each of those circumstances. But ultimately, it's very challenging to say, oh, well, I had this test, and therefore it's an absolute answer, right? And this is an area I feel very passionately about, that many people say, oh, well, I sent a test, I'm done, right? And without really learning the details of what that test does and doesn't do, you don't really know what questions you just got the answers to.
I mean, I like the example where, I mean, sometimes, you know, the pathologists who are hiding behind the sofa, you know, they just issue the report without any concept of, you know, they're just throwing it over the wall. Whereas I think, you know, the consequence of it, and I don't know if you remember, this is a case that we had that had come from Beverly Hills, where they were a fairly well-known minor celebrity, and they'd had a molecular test done for ALK, which they used to do this thing called a FISH test, and you had to have 15% or more cells positive for ALK to be called ALK positive. And the report said that, let's go to get the math right, 86% of the cells do not show an ALK rearrangement. Negative result. So the patient went, oh, I'm ALK negative. And you go, well, hold on. So hold on. So 14% were positive, and 15%.
16.
No, for the purposes, we'll go back and edit this, but for the purposes of this argument, it's supposed to end up 14% in my story. So I can say, if you do the calculation, you're 1% away. And so we redid the test, and they were positive. And
yes, I remember exactly which case you're talking about.
Yeah. Yeah. In fact, you sent me the case. I did. Yeah, he's doing great. He's about 7 years in now. Yeah.
So I did have a question, and then I know we had a couple questions up front, so Danielle says we'll get to those two. You all are obviously involved in, you know, patient education and encouraging patient literacy. So my question is, do you still encounter physicians who are maybe resistant to that, resistant to an educated patient? And what can you say to those physicians, I guess, and both from the, you know, medical perspective, and also I know, Janet, you probably...
I have a few opinions, yes.
Both the physicians and the patients. So I'd just like to hear, and, you know, maybe for people at home who haven't had this same experience, what can you tell us about that, and how can, you know, we all help advance that and change that?
I'm going to take advantage of this to plug the oncogene-focused groups, the ROS Wonders, ALK positive, EGFR resistors, exon 20, and now the RET renegades. The reason we exist is because we have rare cancers, and there are some doctors who will never see another ROS1 case or have never seen one up to this point. And they don't know what is involved in the testing and the appropriate treatment. So we are out there trying to educate the patients so that they can bring the information that's correct to their doctor and become a partner with their doctor. And occasionally they run into doctors who are resistant to that. And if the doctor's too resistant and they won't respond to a second opinion from a ROS1 expert, then we suggest they find another doctor.
Yeah, I mean, so people often say, you know, how do you deal with informed patients? And you go, well, you know, I said before, this isn't veterinary medicine. I mean, that dialogue is actually what makes the job fun. Most of the time.
Most of the time, yeah. He comes in and says, "Okay, show me your list."
Yeah, I think it's important, again, in talking to patients from all walks of life from around this country and tons of others. It's a different experience for everyone, right? So, an educated patient walking into and talking to you people is very different, right? It looks very different, and you're open to it, because you walk, talk, live, and breathe this disease, right? For a physician who might take offense to their patients trying to tell them how to practice medicine, and again, I'm pointing back to challenges in those more rural areas of this country, and it is a challenge, right? Where these patients are. I have had physicians say that they don't want their patients even having access to our education materials because they don't want their patients. They've
really said that?
It.
Wow.
They don't want my patients asking me questions. So it's a real life problem for a lot of patients being treated with the disease, and that's just more of a comment than it is. Anything else to your point, Chris? Okay, sorry.
Firstly, I'd like to say I'm just really happy to hear that universal molecular testing, except for the smallest of stage 1s, is becoming done regardless of whether...
I'd be doing it, but clearly Dara tears up my form.
We had a whole conversation about this.
I have no recollection.
You know, I'm actually a squamous outpatient, and there's not all that many of them around.
Oh, well, that's a great example, yeah.
And, you know, the old standard, I wouldn't have had molecular testing done because I was squamous. And, you know, if someone's a 70-year-old person that smoked all their lives, it doesn't mean that they got cancer because of being a smoker. It might just simply be an oncogenic mutation. They happen to be a smoker, but it's not because of the smoking. So I'm really happy to hear that that universal molecular testing is at least being done at CU, and eventually one day it'll be done everywhere around the world. We can only hope that that day comes sooner than later.
I mean, Dara, you know, had a throwaway comment about the cost, but I mean, you know, it's like the cost of your PC. The cost for the molecular testing is coming down, and so it becomes less of this barrier that people have to think about.
But I think we need to be clear about what the barrier is, right?
Okay.
So the payers tell us that the barrier is that they don't want to pay for the testing, right? The charges...
The payers being like the insurance company.
Right.
Yeah.
The charges for the testing are less than a CT scan or a biopsy. The reason the payers don't want to pay for the testing is because they don't want to pay for the can of worms it opens up. It's not about the test. It's not about the technical charges for the test. It's not about the results of the test. It's about, oh, well, if they get this test, they're going to demand to go on this drug, and that drug costs me a lot more than a platinum doublet. Hands down.
And if you're on the platinum doublet, then you die. If you're on the platinum doublet, you'll probably die soon, and then they don't have to keep paying insurance.
Well, yeah. So health economics is the cheapest patient is a dead patient, but yeah.
I mean, and I'm not saying that they don't want to allow appropriate use. I think that payers want to allow appropriate use. You get a molecular test and it shows you have an ALK rearrangement, you'll get put on the appropriate therapy. But you get a molecular test and it shows an NTRK fusion, right? Drug is not yet FDA approved. What do we do now, right? Better example is a RET rearrangement. There is a drug that's FDA approved for RET, but not in lung cancer, right? So now does the insurance company want to pay for an off-label use? That's the can of worms they don't want to open up, is the off-label use.
Well, but that works both ways. So one is, there is a drug out there that's really useful, and you know, if you move away from the kind of paternalistic approach, just because it's not in your practice, if it's me, I want to know that because I want to be in control of my life and say, well, I choose to go to this other place for a clinical trial. But then the other side is, well, part of the can of worms is some of them really are meaningless changes where you could waste a lot of time and money chasing down drugs which actually won't work. And so not every mutation and the information on the bottom of some commercial reports actually that says, sure, you have AKT mutation, therefore you should go on an mTOR inhibitor. I mean, that's complete nonsense, and yet they're still listed.
Well, and I've also heard the other can of worms is that not all doctors are as educated about these mutations as this team is. So their patient comes to them with a report that has all this information, and they don't know how to read it or what it means, and they don't know who to ask. So it actually complicates their lives, and they don't know what to do with it.
I think, too, that the payer situation is not unique even to molecular testing and targeted therapies. We had a patient whose insurance company agreed to pay to have fiducial markers placed and then denied the treatment. So it's like,
that's bizarre.
It's ridiculous, right? She fought her way up and obviously got the treatment done, but they actually denied the treatment after the markers were placed. So I mean, I think there's still, I think part, sorry, because I don't want to make sure. I think that one of the challenges, things are happening so fast and furiously. So this points back, Kristen, to your point about the physician education, particularly in the more rural areas. Ross, you touched on NCCN guidelines. In the last 18 months, how many times have they changed? Right? So if you're a general oncologist working in the middle of City X in some rural area, and you looked at them a month ago, and you don't know they've changed, you don't know they've changed, right? Yeah. So that's also one of the challenges behind it.
Just a very short technical question. How much tissue sample do you need for molecular testing?
Oh boy, I get this question all the time. So it's The answer is honestly, it depends. And I know it's not a very satisfying answer.
What is the least you've been able to get away with?
Couple hundred cells.
Okay. If I was a commercial testing company, what's the least I could get away with?
20,000 cells.
Okay.
The answer to that is I can do a very small amount with a very small amount of tissue. The more you want, the more I need, right? But labs are also pioneering ways to sort of think beyond, think outside of the box on this, right? So I mentioned fine needle aspirates, right? An FNA is, as I mentioned, long, thin needle, negative pressure. We suck cells out of a lesion, right? Squirt the cells out on a slide so we can look at them, right? Now, unlike a slide that got cut, like the one I told you about before, now instead of looking at slices of tissue, I'm looking at whole cells in blobs on a slide. Historically, this has been a big part of our medical archive, right? And it's really, really common in our radiology suites that if somebody's been, if a biopsy's been ordered on a patient, the interventional radiologist, okay, I'm going to get the needle this way, and I'm going to do this, and I'm going to do that. But they ask for a pathologist to come down to the suite, and right there, while they have the needle in the patient, they put a little bit on a slide, and the pathologist says, yes, I have lesional tissue, right? And that helps not only know that you're in the lesion, but it also helps that pathologist who went to that procedure to say, okay, I have lesional tissue, but I know molecular is going to want more than what you just gave me, right? But then the part where we're trying to innovate is I and many other labs, I can actually take that slide that they use to make that initial call, and I can pull the tumor cells off of that, right? Now, it happens that the quality of what I get off of those tumor cells is vastly superior to what goes through all of those chemicals, which is why I can do it on 200 cells.
But I think it's true that there's a wide variation across the country on the way that people capture biopsies and how they save the material. So something that works at one hospital won't be sufficient in another hospital.
Absolutely.
Yeah.
That's absolutely true.
Well, I just have to say, I asked for a second opinion before I even had my first opinion. So, Dr. Kamich was my second opinion. And as far as a whole plan and a whole group of people that, that are on my team, I always consider him as part of my team, even though he's not my doctor.
Well, your first opinion, we trained.
Yes, I know.
So
That's really great, which I didn't know beforehand. So.
Yeah.
But I just wanted to say, when I did see you, from my second opinion, I had already had an FNA done. And when looking at that FNA, I didn't have EGFR, I didn't have ALK, I didn't have any of those. And yet it was determined that you really needed more tissue. So I did go ahead and do a core tumor biopsy, to get that tissue. Had the molecular testing done, which my insurance did not pay for. But it was really important to me to have that done, and so we did get it done. And I guess where I was going with that is that even with getting all of that done, I still did not have a targetable mutation that we could do, and I did end up with chemotherapy. I have done chemotherapy for 2 years. And just took the chemo out and still on an anti-angiogenesis for the past almost 5 months. So, I would like to just say to people that don't have a targetable mutation that sometimes chemotherapy works, sometimes these other things work, and so there is definite still reason for hope, and all the different things that are the different. What we're finding in the research, I say keep going with that, because one of the 6 mutations that I have eventually, might show up there. And so, just keeping, all of us that, are on chemotherapy stay alive long enough, to where there is something that is going to make a difference, for us as well. And so I do appreciate everything that all of you are doing.
And I want to also build on something that you said in terms of getting a second opinion, because Colorado was my second opinion, and now my home oncologist in Seattle talks to Dr. Camage whenever he has issues about targeted therapy. So.
Yeah, I like Joe. He's a great guy.
He is, yeah.
I want to thank you for that statement because it's so important. What you said, and the clock is ticking on our couple of hours here. So there's a couple of things we didn't get to that I want to touch on. One, you talked about the research and being able to manage your disease, whether it be with a targeted therapy, an immunotherapy, chemotherapy, combination therapies with radiation, whatever your therapy looks like. Keep at it, keep strong, and keep talking about it and coming to these meetings and encouraging other patients to be as hopeful as they can be in this place. But that points back to clinical trials and the importance of speaking to your doctors about those. In one of the education pieces that we provide, our patient education handbook, Dr. Camage actually wrote a paper, a very patient-friendly paper, explaining clinical trials and gave us permission to publish it in the book. So if you don't have the book, please talk to Michelle or I or Kim, because it's like guinea pigs, poodles. I'm forgetting right now off the top of my head.
Guinea pigs, test pilots, and prize poodles.
Test pilots and prize poodles,
Yep.
yes.
Woof.
Yes. And there's like a poodle with pink hair in there or something. Anyway, it's a really great explanation of clinical trials, what they are, what you can expect, based on different phases of trials and why it's important to participate. So that's one thing I wanted to touch on that we didn't get to touch on much, and that's a whole living room all by itself. And number two, for those watching online, maybe not in the Colorado area, who are interested in a second opinion, potentially with the team from University of Colorado, they do a really, really amazing job with their remote second opinions. And I know out in California where we are, and patients call us all the time looking for second opinions, but they are in some more rural areas and don't have easy access. We work with Bethy over at the university, who is absolutely amazing at working with patients that we send to her to ensure that the second opinions from this team can be made for all of you. So if you guys are interested in that, you can either go to University of Colorado's website and or contact the foundation at any time, and we can hook you up with an opinion there. So with that, I want to close with a final question before I get to thank yous for coming, and that's Bonnie's question, which is, and it's to the entire panel, and Ross, I'm going to start with you, is do you see chronic management in the future of lung cancer?
Yeah, well, if I give you an example, so we just submitted a paper, so academic hospital, but that's our currency, on what's called the median life expectancy of patients with stage 4 ALK-positive disease. So median, before you fixate on the number I'm about to give you, is just 1 point, which is the 50% point, but there's obviously a range around it, and it's about 7 years. And sure, that's a lot better than a few years ago. If you go hit Dr. Google, you're diagnosed with stage 4 lung cancer, you think you're going to be dead before you finish reading the page. 7 years is good, but if you're 35 when you're diagnosed, that still sucks. So it shows to me the potential, but I don't think any of us are ready to retire just yet, because I think there's still a lot of work to do. So when we get to the point where people are measuring their life expectancy in years, and if not in decades, then some of the things that we ignored in the past will start to come out. And some of it is, it's not, staying alive at any cost. I want to have a normal quality of life. A pill that, gives me torrential diarrhea or a rash, maybe that's a deal breaker now, because my expectation has gone up. I want to be normal. And so I think some of the kind of clunky first through, the kind of, last of the Mohicans, just stay alive kind of approach is going to evolve, and we do want to turn it into a chronic disease. So I think we are getting examples where we can prove that it's possible. In the same way that we've said it's not one disease and we have to personalize things, we're going to have to find those solutions for every single one of these subtypes of disease hiding under the umbrella of lung cancer.
And this is, I think, so important why patients be advocates for their own disease. And we were talking a little bit earlier, I was talking with one of the patients in the room tonight about what you said about you know, what's a go, no go for me? And that's different for all patients, right? Mm-hmm. The side effects and quality of life, what someone's willing to tolerate and live with is different than what someone else is, which is why it's so important that conversation happens, right, at some point in the care. Dr. Rusthoven.
Yeah, I agree with what Ross said. There's been amazing progress for subsets of people with lung cancer. But there's a lot of people that haven't benefited yet from a lot of these great advancements. And so it is becoming specialized. Lung cancer is becoming many diseases, and the way that we think about a person with a newly diagnosed cancer is heavily influenced by their molecular signature. And as a radiation oncologist, I do have to start thinking about the longer term effects of the interventions that we offer in a way that that we didn't 10 years ago. And it gets to kind of one of the questions I was asked earlier about how you choose focused radiation versus larger field radiation or whole brain radiation for someone with brain metastases. That conversation looks a lot, that looks much different for a patient who has a prognosis of 7 years than it might for someone who has a much shorter prognosis. And so it is making us kind of embark on new frontiers of ways to treat cancer, to try to minimize side effects and to take those things very seriously today.
And a point I will make on that before we move to Dr. Eisner is pay attention to your side effects. There are no stupid questions. Talk to your care team. We hear patients all the time where their side effects actually become worse than their disease, and they're fearful of either bothering their clinical team and or fearful that they're going to be taken off drug if they, you know, suggest to the clinical team that they're having adverse events. So please, please, please talk to your care team about side effects. Very, very important.
Well, I think that we've hit a point in the diagnosis and management of lung cancer that's really at an inflection point. And we talk about the pieces of the pie that we've learned a lot from, EGFR, ALK, ROS1 being the biggest examples. But that's really the front edge of a very big wave. And you know, when I see all of the things that are coming down the pike in terms of how we approach therapy, how we approach diagnosis, how we approach monitoring, how we approach plucking the weeds, I think that lung cancer can become a chronically managed disease. And I think that there's lots of precedent for this, right? And you know, focusing a little heavily on the targeted therapy example is still an outstanding example where the key precedent in this is already a couple of decades old, but the whole premise of targeted therapy evolved from designing a drug for a disease called chronic myelogenous leukemia, CML, which when it hit its aggressive phase was a very bad actor. And this is now truly and honestly a chronic disease. We monitor it with a blood test to check and see how people are doing. And I really foresee that is where we can and should be aiming.
I think, just to comment on that too, clearly I have a lot of comments based on comments tonight, but that's a really, really great example, especially when you're looking at the blood diagnostics that we barely got to touch on tonight, and sort of where they're going and how much more quickly they're getting there than I thought they would when it first started. So all very, very positive. Janet, do you have any final thoughts on how you feel about this?
Just to build on what you said about Gleevec, there was a discussion online just recently that the patients who are now on that targeted therapy, which just got approved in 2001, actually have a life expectancy that's approaching normal. I would love to see us get there. That said, in lung cancer, it's a little different to be chronically terminal, when we still can have our next scan and find out things have changed. When we have, some of us are living long enough on targeted therapies that we're starting to get late effects of radiation that no one had seen before. So I'm very hopeful in the direction we're moving, but I'll feel more hopeful when we have it for all types of lung cancer and not just the few of us who have targeted therapies.
Very excellent point to end on. from the patient perspective, and the patient voice, we say from the foundation, is oh so important. So thank you for that. With that, I'm going to get to some, before we say thank you to this panel and all the people, and I need to thank our sponsors. You know, like I said when I'm going to stand up again, but like we said when I opened this meeting, that we do this for you, we bring it to you in hopes that you are benefiting from what the expert panels that we bring up have to say. So we could not do that without the support of the very long list of people I'm about to name. So AbbVie, Lilly Oncology, Medtronic, Merck, Novartis, Takeda, Celgene, Bristol Myers Squibb, Boehringer Ingelheim, AstraZeneca, Amgen, Genentech, and the Yahoo Employee Foundation all support annually this meeting so that we can bring it to you. So a huge thank you to them. Thank you to the JW Marriott and the catering crew for bringing us all the food tonight, for the production company for coming out here very early this afternoon, getting everything set up and bypassing the glitch that we first started with. Again, apologies to the people who are online. A huge thank you and round of applause to our panel tonight. Round of applause means clap. Bringing us this very relevant information. We're really excited with our very first turnout out here in Colorado. We can't wait to come back again next year.
You'd be very welcome.
Thank you. And last but not least, and foremost, actually, thank you to the patients and the caregivers, their family members in the room, online, for coming out. Like I said, we do this for you. So thank you. There's dessert. Please get dessert. And hopefully, what? You want to thank somebody? No. What? What are you doing? Oh, his joke about dessert. I'm not going to throw it at you. I promise. He joked that he was going to talk too much, that I was going to throw it at him. But you were oh so gracious. You let everybody else talk more.
Yeah.
I know.
You were all heard from me. These guys need some airtime.
I know. Thanks, everybody. Have a great night.
You even let me talk.
It was there.
Sitting and drinking. I mean, essentially, I took an entire thing of those little honeys and I dumped it in here.
The big question obviously is always like can we actually do that?